I am extraordinarily excited and pleased to turn to Christina Rabadon-Deal, who wears so many hats, including those of a Shatterproof ambassador, advocate, and leader in the substance use field. I will her to share with us why this event and why addressing addiction stigma is so critical, and to share how she addresses it herself. Christina, over to you.
Thank you so much, Rachel. So welcome everyone to the beginning of an incredible journey together. For the next few hours, we will be discussing many topics, all relevant to addiction stigma. But most importantly, we will be creating a path for action so we can take the knowledge and tools we will gather today and start breaking the walls that isolate people with substance use disorders and their families. I know all about walls, isolation, and silent fears. I am one of the people in our country who has been touched by the opioid epidemic. As a matter of fact, tomorrow, June 9th, will be 3 years since I last saw my son, Jonathan, alive on my birthday. I am not here to tell you what it means to have your heart and your life broken into a million pieces, because I got the feeling that unfortunately, many of you already know, either firsthand or know of someone who's died or is impacted by this terrible disease of addiction. The numbers speak for themselves, loud and clear, as it was said. More than 107,000 overdose deaths in the last 12 months. I am here to tell you, however, how I was able to take my pain and my deep sorrow and turn it into action. You know, some people tell me that not everyone has the knowledge I have or the contacts. But it really is not about who you know or what you do. It is about determination. It is about looking outside and beyond yourself. And most of all, it is about love. Yes, I am a scientist and a health professional, but I am first and foremost a mother who lost her son. And that is the engine that drives me every day to do what I do now. I have spent a lot of time reflecting on Jonathan's life and his journey. I learned that stigma touched his life in so many ways. Stigma that came from his teachers, his peers, his medical care providers. Stigma also that sadly came from us, his family. We will get sometimes angry, and tell him to take responsibility, to get his act together. We were so influenced by what we believed a person with SUDs might look like, behave like, that we tried to find any alternative explanation, any excuse, any reason to justify his behavior. We told ourselves that he didn't act like someone who had an addiction problem, as we thought we knew. We were so ignorant and so influenced by our own stigma. But frankly, we also were terrified and paralyzed with fear. He kept his addiction to himself in silence as his self-stigma grew and prevented him from talking about it, from seeking help. And when years later we learned that it was a disease, we did everything we could to talk to him, to persuade him to go into treatment. We told him that he was sick. But his self-stigma and his stage of addiction were such that at the best time of his life, he relapsed and fentanyl took him away from us. Shortly after he died, I realized that I had to do something with the love that I have for my son. I could no longer hug him, but I can hug others in his name. I could take his kindness, his loyalty, and desire to help others, and could build his legacy. So I started this journey. I knocked on many doors, wrote so many emails to people I knew or I didn't even know, just saying, I am here. I want to help. And you know, nothing happened for about a year. And my love for Jonathan was trapped together with my sorrow, with nowhere to go. But I didn't give up. I kept trying and trying and trying until one day things started happening. And I started connecting with people, learning about addiction, got invitations to speak and to be part of committees. Early on, I decided that I will break my own stigma and fear of judgment towards my son or my family, and realize that the only way to start walking the path of hope was speaking up. Today, I call myself an SUD advocate and knowledge broker because I combine all my technical and personal expertise and build bridges among communities. I am also very committed to equity issues, as I realize that while the disease of addiction doesn't discriminate, inequities exist when it comes to access to treatment and information. I am a native Spanish speaker, and I have worked with the Hispanic community for more than 30 years. So I am helping to close the gap and bring culturally competent information and programs to our Latino families and communities. I am also a strong believer that any effort that we make to gather multi-stakeholders to address addiction issues must have representation of patients and families. Look, I know it is not easy, believe me, especially to have to be the voice of those who no longer can speak for themselves. But patients and family-based organizations have been shown to be extremely effective in other diseases. And in this case, it shouldn't be any different. So today, we will be able to hear many perspectives, from healthcare to the carceral systems. We will explore the role of advocacy and how systemic racism and stigma are related, and many more. My hope is that we will pay close attention and that each of us will decide what is the area that generates passion within ourselves. And then that you will join me and many others in this journey. Today's summit is a call to action, and we all have a critical contribution to make. No matter where you come from, where you live, what are the tools in your toolbox, your voice matters. Because at the end of the day, it is the love that generates commitment, and commitment what brings change. So let that love and that commitment guide us today as we continue to build a better future for those afflicted by substance use disorders, their families, and communities. Thank you very much.
Thank you, Christina, for those incredible words, for your story, for your work, and importantly, for sharing Jonathan's story with us. You truly are an inspiration to us all, and I encourage all of us to take that thought about building a toolbox with us throughout the day. In that vein, I am now pleased to introduce Dr. Ann Crendel, Associate Professor at Indiana University. Dr. Crendel, alongside her colleague, Dr. Bria Perry, partnered with Shatterproof to develop and publish the Addiction Stigma Index, a first-of-its-kind measurement tool designed to assess attitudes about substance use and people who use substances from the public. Gary did a fantastic job of explaining why this tool is necessary in his opening remarks. We recognize the critical importance of measuring attitudinal and behavioral change when working to reduce addiction stigma. And as such, Dr. Crendel is with us today to discuss the index, its methodology, and its utilization. Dr. Crendel, I'll turn it over to you.
Thank you. So I'm going to show you today some of the results of the Shatterproof Addiction Stigma Index and walk you through just an overview of what the study looked like and what the design was. I'll start with something I probably don't need to start with in this audience, but just to set the stage that, of course, substance dependence is a prevalent and deadly problem within the United States. We know from some work that Dr. Perry and I have done together that there's a variety of reasons why people don't seek treatment for substance dependence. But stigma has been identified in much of our work as one of the main barriers that people face. So in addition to factors like not being able to afford treatment, not considering their dependence to be a serious problem or not having time, avoiding stigma has been identified by large samples of the populations we've interviewed as being a major barrier to seeking treatment. And it turns out that stigma isn't a barrier on its own. We found in other work that it interacts with many of these other barriers and makes those barriers more pronounced in reducing people's willingness to seek treatment. So the goal of the Shatterproof Addiction Stigma Index was to try to better understand the nature and magnitude of stigma toward different substance use disorders. So the index was conducted in collaboration with Shatterproof and the Hartford. Dr. Bria Perry at Indiana University and I collaborated with them in the spring of 2021. So just as a full disclosure, we were subsidized for our collaboration on this and paid as consultants to collaborate on this project. The goal of the index was to try to understand what the nature and magnitude of stigma toward different substance use disorders was in this country. So the study was implemented by Ipsos using the Knowledge Panel. This is an online platform. And the data were collected in middle of July to end of July of last year. The goal of the survey was to try to capture two different aspects that I'll speak of today. One was attitudes by a representative sample from the general population in the United States. So these are individuals over the age of 18 residing in the United States. Ipsos fielded the survey to about 11,000 US adults, and of those, we had about a 60% completion rate. So this is a purely representative sample of the United States to give us some sort of flavor as to the attitudes toward different substance use disorders in the US. In addition to looking specifically at this representative attitude, we also were interested in a few specific subsamples of the population. And so there were some oversamples that we did within the overall distribution, including one that I'm going to speak briefly about today, which was an oversample of healthcare professionals. So Ipsos actively recruited on top of the general population, an additional group of people who identified as healthcare professionals who essentially work in some domain of healthcare. And this is broadly construed. What we did in the design of the survey uses a very standard approach for measuring stigma that's been used in a variety of nationally representative surveys looking at stigma toward mental illness, as well as substance dependence. And it uses something called a vignette approach. So we wanted to focus specifically on stigma toward 4 substance types. The ones we selected were alcohol, heroin, prescription opioid use, and methamphetamines. We chose these for a variety of reasons. Alcohol is the most prevalent substance use in the US. Heroin and meth have shown, and opioids have shown, and at least have been implicated in some of the dramatic increases that we've seen in overdose rates recently. An additional vantage point of using heroin and meth is that these are considered to be illicit drugs, whereas alcohol and prescription opioids, people tend to see them and characterize them differently and see them as being not necessarily street drugs, but things that are more easily accessible. Within prescription opioids, I'm not going to go into the details of this, but just to fully acknowledge this, we actually looked at opioids with 2 different onsets. One would be an addiction that developed from opioid use based on having been prescribed opioids for a medical condition by a physician. And another case would be having developed a dependence to opioids from having recreationally used it. And so we specifically described an onset where the individual was at a party and started to use it recreationally. The setup of this used something called a vignette approach. So a vignette approach is a really standard way of trying to measure stigma and attitudes toward different conditions. What you do in a vignette approach is you describe a scenario of someone, in this case, we name the person John, and you describe a scenario in which this person had developed an addiction. And through this, the critical piece of this is you never actually label what this individual is going through. You speak specifically to the symptoms, and these are DSM-defined symptoms. that are very clearly pointing to the individual having developed a substance use dependence, but you don't explicitly label it. Once you label it, the attitudes shift in very dramatic ways. So individuals read a vignette in which they were randomly assigned to one of these substance type conditions, and then we asked them a series of questions. For half the participants, we included in this vignette a recovery aspect. So for half of people, they saw this added bonus at the end in which we described the individual as being in active recovery. And this will be relevant for thinking about the data and also thinking about potential implications for interventions. We measured a variety of different attitudes and beliefs about the individual John that we featured in these vignettes. I'm going to highlight 4 of them. 2 were directly related to stigma. These are very standard measures of stigma that are used very widely in our field. One is referred to as something called social distance. The other is referred to just general prejudice. But we also looked at sources of stigma. So specifically, we looked at things called causal attributions. So these are things like how people, what people blame, how people make blames and attributions about why that individual has the dependence that we've described, as well as their own personal contact with people with substance dependence, which turns out to be a very important predictor of whether or not people have high or low stigma. With respect to the attributions, the reason I'm highlighting these is that there are 2 basic categories here of the causal attributions. One is what we call personal attributions. So saying, for instance, that the person's dependence is due to their having bad character or the way that they were raised. These types of attributions have been widely shown to increase stigma. Whereas conversely, you can think about attributions about the individual's knowledge about the substance dependence. So for instance, John's disorder is due to some sort of chemical imbalance. And these are the types of attributions that people often target in knowledge-based and education-based interventions. So let me show you first just a few of the key findings from the index. First of all, we found that prejudice and social distance, these are our 2 measures of stigma, were high. This is a 1 to 4 scale. So I'm showing you here on the y-axis, the higher bars mean more stigma. You'll see on the x-axis, these are the different types of substances. I'm focusing for the purposes of this talk specifically on the prescription opioids with a recreational or party onset, but it looks very similar to the opioid dependence with the medical onset. And essentially a key point to take away from this is that heroin and meth are stigmatized to a much greater extent than alcohol and opioids. So there's this illicitness of the substances seems to be associated with higher stigma. What I'm showing you here now is breaking this down by those vignettes for the individual who was either actively using or in recovery. So what you'll see as you look across these bars, so the graph on the left is showing you prejudice, the graph on the right is showing you social distance. These are both measures of stigma. They're showing the same patterns. I'm just showing you them both for just transparency. And the way I've broken this up is that the bars next to each other are, you'll see, for instance, alcohol either with the individual depicted as being in recovery or the individual still being described as actively using. And the main things to take away from this is that when the individual is described as being in recovery, the bars are lower, which means stigma is lower. So simply by telling people that the individual was in recovery, we saw much lower levels of stigma. And the most important thing to note with this is actually the magnitude of stigma dropped most significantly for these illicit drugs. So for heroin and meth, we saw the biggest drop in stigma when we depicted the individual as being in recovery. Stigma was still higher in those cases than it was toward individuals who were either having alcohol dependence or opioid dependence, but it was dramatic. It showed the most robust drops. The last thing I just want to touch on is some work that my postdoc, Lucas Hamilton, did with one of Bria's students, Max Coleman, which looked at the types of attributions people make and whether those predict their stigma. I'm going to focus on social distance here. This is going to be a little bit of a crazy plot here, so bear with me for a second. But the way I want you to look at this is the straight line. So if there's a solid line, it means there's a significant relationship. And if that first number that you see there before the 95% is positive, it means that if people make that attribution, there's more stigma. And if it's negative, it means there's less. So what this is showing is that for most people, making an attribution that the person's their condition was due to bad character was associated with very high likelihood of increased stigma. Knowledge did decrease stigma, but you'll see these numbers are lower. So it's a little more than half of the effect. For the general population, when we considered contact, so if they knew someone with this condition, we found that knowing someone with this condition, this is the box on the left, makes you have lower attributions that the person had a bad character, which still is leading over to stigma. What's important here is that when we looked at the same relationship with healthcare professionals, we actually found that contact was much more effective in reducing these bad character attributions, which help move stigma the most. And this is important because knowing someone also increases your knowledge, but that has a much smaller impact on reducing stigma. So the most effective way that we found in these data for reducing stigma was particularly for the healthcare professionals in having this increased contact to really target those bad character attributions. So just in closing, to summarize what I've told you, the index revealed that stigma differs across substance types and was the highest toward illicit substances. But emphasizing recovery seemed to have a strong impact on reducing stigma, particularly for illicit substances. The last set of the data that I showed you suggests that while we often may gravitate toward using education-based interventions to try to reduce stigma, they may not be as effective in reducing stigma because they're not addressing another key component of a driver of stigma in these cases of substance dependence, which is these bad character attributions. However, the positive note here is that contact seems to be really effective in targeting those negative attributions and may be a really important target for future interventions. So thank you very much for your time, and I look forward to seeing the rest of the summit today.
Thank you, Dr. Crendel. That was incredibly insightful, and thank you for your time over the past year plus, really devoting your time to working on the Addiction Stigma Index and measuring change. Your work has already shown incredible potential and helped us move the needle on evaluating addiction stigma efforts, and we truly appreciate it. Alanna, over to you.